Dr. Samuel Washington.
What I want to cover today is really the pathway. So, how do we go from evaluating prostate cancer, talking about screening, what tests, options there are for evaluation, all the way to treatment? And my goal really is to inform everyone what the options are. So, when and if that time comes, you know what questions to ask. And that's really the goal of this. So, I'll start by going through background, talk about the evaluation and workup for an elevated PSA, and then what do you do after the diagnosis? What are the potential options? What are the questions you should be asking up front to make sure that we get the best care? Now, overall, we know prostate cancer continues to be the most commonly diagnosed non-skin cancer across the United States. For us, it accounts for 37% of new diagnoses for Black men. That's nearly 42,000 diagnoses of prostate cancer this year alone. And for everyone, all men, it continues to be the second most common cause of cancer deaths. That's 17% of deaths, over 6,000 men in 2022 attributed to prostate cancer. Now, the key to really decreasing that and decreasing the increased burden that we have or we experience due to prostate cancer is early detection and early screening. And I always emphasize that the blood test is really the first test or the first step to get this discussion going. Now, we know that overall, across the past few decades, cancer rates have decreased, but there have been many contributing factors that have led to us getting higher rates of death compared to other groups, decreased rates of screening, potentially earlier onset of disease, diagnosis at a later stage, as well as the quality of the care that we receive overall. So I'd like to start and just have everyone understand for whom we are trying to screen. And for all of us being Black or African American in the United States puts us at higher risk based on multiple different studies. But in addition, understanding our family history. Do we have family members that had prostate cancer or died from prostate cancer? These are really the groups that should consider definitely talking with their primary care doctor or other providers about screening and potentially screening earlier than the 55 to 70 years that is traditionally kind of reported in our guidelines. There is a caveat, and we discussed that a lot of this is centered around life expectancy. So people over the age of 70, or if there's a life expectancy less than 10 years, there are further discussions about whether or not screening will be beneficial. But the bottom line is to understand that we are of a higher risk group and that there's no universal cutoff. All of these things that I'll discuss help us assess risk. There's no PSA level that will tell you you absolutely do not have cancer without any workup, okay? Previously, we talked about PSA of 4 being above that, concerning, being below that, not concerning. But even that paradigm has changed. We realize that these PSA levels change based on how old you are, how big your prostate is, other factors. So it's really how do we assess your risk well early enough so we can have a good intervention and prevent deaths due to prostate cancer. So the steps of this are really to have the discussion. So it's talking with your primary care doctor, your GP, understanding that we're in a high risk group, understanding that we need to know if we can whether there's family history of this, and know if we've had PSA tests before, what those numbers may have been. If we haven't gotten screened before, we should get that PSA baseline test. Even if our primary care doctor says there's no point in that, thankfully, urology as a field has learned over the last few decades, and we understand that we need to be smarter about our screening, but we're all in the high risk group. So it is worth having that discussion and getting that baseline. And even our guidelines clearly define what we should be doing next. So thankfully, we're not all jumping to big interventions, but we're doing this largely based on risk. Now, say you got the blood test, the PSA says it's 5. What do I do? Do I have to go straight to a biopsy? The answer is no. There's actually a lot of other tests that are less invasive than the urologist handshake and a prostate biopsy that can help us, again, assess your risk of having cancer that would impact your lifespan. Now, one of those are biomarkers. That's just a fancy term for urine tests or blood tests that, again, help us identify how likely it is that you have aggressive cancer that would impact your life. These things don't require a prostate exam, a digital rectal exam. They don't require an ultrasound going into the rectum. And all of these things can be done before that biopsy step to help us better understand what's going on. So if you have an elevated PSA test, this would be an opportunity to ask, okay, what other tests could I have? Is there a blood-based test? Is there a urine-based test that may help us figure out what's my risk of having cancer that will shorten my lifespan? In addition, one other option would be an MRI. So the question would be, okay, my PSA is elevated. Can I get an MRI of the prostate? How does that help me? That shows me a picture of the prostate. It shows me how big the prostate is. It tells me how elevated your PSA is relative to the size of your prostate. So bigger prostate, you may have a bigger PSA. Smaller prostate with a big PSA, that's more concerning. In addition, the MRI shows us places that look abnormal compared to the rest. So it gives us a target if we go on to the biopsy step of identifying that area and biopsying that specifically, so we decrease the risk of missing aggressive cancer that will impact your lifespan. Now, our biopsy, I don't know anyone that's excited to see me in clinic when it comes time for a biopsy, but that is really the only way to know with our current technology if cancer is present or not. These blood tests, the PSA tests, the MRI give us estimates, give us a good idea, raise our suspicion, but nothing compares to tissue under a microscope yet, unfortunately. So it really matters if you have a biopsy and how it's done. Our guidelines say there's a minimum number of cores or samples that need to be taken, these hair-like little strands of the prostate that we can look at under a microscope to understand what's going on. If we see something on the ultrasound or the MRI, that's an opportunity to identify potentially that little nodule of aggressive cancer, so we know exactly what's going on in the prostate. And again, this is done in clinic. You don't need to fast beforehand. We give local anesthetics. So I always tell my patients, no one's ever fallen asleep when I've done a biopsy, but people are usually asking me questions throughout. So that kind of gives you a sense of the level of discomfort and during the procedure. Now, even after the biopsy, say you have your score back, you're like, doc, what can I do? Are there other things that we can do with my biopsy tissue to look at this tumor to figure out what's going on? The answer is yes. Here's a list of a few of them. But the key really is to ask that question. What else can we know from this tissue that's already been taken out? This helps us figure out where you are on the risk panel, figure out what treatments may be best for you. And I really rag on my own field and take kind of the mystery out of it, but everything is a protocol. Everything is an algorithm now. And it's not really to memorize the chart on the left, but to understand the parts that go into this. So the important things to ask are, doc, what's my Gleason score? What's my grade group? What risk category am I in? Are there other tests that need to be done? Do we need to do tests on the biopsy tissue? Do we need to get other imaging, like a PET scan of any type, to understand the level of disease, its aggressiveness, and where it is in the body? Now, after that, understanding where you are, what risk group you're at, where the cancer is. Is it in the prostate? Is it outside the prostate? Is it pushing on the edge of the prostate trying to escape? That really defines where you are in the treatment pathway. Is there an option for active surveillance? So for us to monitor this disease closely and offset the upfront risks of surgery or radiation, or is this a more aggressive tumor, cancer, that we need to take out? And that's when we talk about radiation or radical prostatectomy, surgery to remove the prostate, radiation to treat the prostate while it's still in place. If we don't catch it when it's inside the prostate, what treatments are there to really control this cancer and prevent it from spreading further? And these are the questions that really push the doctors to talk about all the risks and benefits. We are always told to participate in shared decision-making, but I would say all of us need that nudge. And this is a good opportunity to make sure that all of these options are being discussed. Now, active surveillance. For people who have low-grade, low-risk disease, it is an option. It's not the same as ignoring the disease and pretending it didn't happen. It's not the same as waiting for symptoms to come up. It is close monitoring with PSA tests, with biopsies, with imaging and other tests to truly understand what is happening with your cancer over time. Doesn't mean you may not need surgery or radiation at some point, but you may not need it right at the time of diagnosis. It's really to avoid the costs, monetary and functional impacts of treatment up front. And again, it doesn't mean that at some point you may not need treatment, but do you have low grade cancer that we can monitor closely and then identify at some point a small change before it becomes a big problem? It's all about the timing of treatment. That is what we discuss when we talk about anyone who has a diagnosis and what their options are for management afterwards. And you'll just see that over time within UCSF across the country, more and more men are being treated with active surveillance, but largely it depends on where you are in the country. Unfortunately, we know treatment in one area of the country is going to differ for many different reasons to some other place in the country. And we know that even down to the county level, you're going to see differences in care. So this is really an opportunity for us to ask the right questions to make sure we're getting the options that are discussed with everyone else. Now, across that prostate cancer team, you're going to see a lot of different practitioners. It's largely a team effort at this point. You're going to talk to radiation oncologists about radiation. You're going to talk to surgeons like myself about active surveillance, radical prostatectomy. If the disease is outside of the prostate, you may even start talking to medical oncologists and a combination of all of us to understand what the best treatment options are for your particular situation. But again, that is all dependent, and this is a great opportunity for us to ask the right questions so we know what the options are. Perfect. And that's the bulk of my talk. Thank you for having me.